This recorded lecture will be going over Chapter 25, The Child with a Respiratory Disorder. Ventilation is the process of breathing air into and out of the lungs. The differences between the respiratory tracts of the growing infant and that of the adult will be shown in Table 25.1 on page 595. A cold, also known as an acute coryza, is the most common infection of the respiratory tract. The age, state of nutrition, and general health of the child will all contribute to susceptibility level. The common cold differs from allergic rhinitis in that a child who has allergic rhinitis has no fever, no purulent nasal discharge, and no reddened mucous membranes. Sneezing, watery eyes, and itching of the skin are the primary manifestations of allergic rhinitis. Children's air passages are smaller and more easily obstructed. Fever as high as 104 degrees Fahrenheit is not uncommon in children younger than 3 years of age. Nasal discharge, irritability, sore throat, cough, and general discomfort are present, and there may be vomiting and diarrhea. Complications of a cold include bronchitis, pneumonitis, and ear infections. There is no cure for the common cold. Treatment should begin early when a cold is suspected. Treatment includes rest, clearing the airways, adequate fluid intake, prevention of fever, and skin care. Moist air will soothe the inflamed nose and throat. Acute pharyngitis is an inflammation of the structures in the throat. This infection is common among children between 5 and 10 years of age. Symptoms include fever, malaise, dysphagia, and anorexia. Conjunctivitis, rhinitis, cough, and hoarseness with a gradual onset and persisting no longer than 5 days are characteristic of viral pharyngitis. A strep throat is determined by throat culture. When the culture is positive, antimicrobial therapy, like penicillin, will be administered orally for 10 days. Prompt treatment of strep throat is important to prevent serious complications like rheumatic fever, glomerulonephritis, paratonsillar abscess, otitis media, mastoiditis, meningitis, osteomyelitis, or pneumonia. The maxillary and ethmoid sinuses are most often involved in childhood sinusitis. The signs and symptoms of sinusitis in children are different from those in adults, depending on the age of the child and which sinus is fully developed. Treatment will typically involve a 10 to 14-day course of antibiotic therapy. Croup is a general term applied to a number of conditions whose chief symptom is a barking, croupy cough and varying degrees of inspiratory stridor. Acute croup can develop into a respiratory emergency. Some infants are born with a weakness of the airway walls and a floppy epiglottis that causes a stridor on inspiration. This condition is congenital laryngeal stridor, and it typically clears spontaneously as the child grows and the muscles strengthen. Spasmodic croup typically occurs in children between 1 and 3 years of age, and it can be caused by a virus, allergy, or psychological trigger. The viral condition laryngotracheobronchitis is manifested by edema, destruction of respiratory cilia, and exudate, resulting in respiratory obstruction. Stridor develops and classic symptoms of respiratory distress follow. Parents are often instructed to increase the humidity levels around the child. The child can also be taken into the bathroom, where hot water in the shower is turned on to increase humidity. When continuing symptoms of respiratory distress necessitate hospitalization, the child may be given nebulizer therapy or placed in a mist tent or croupette. Oxygen should be provided to reduce hypoxia. Nebulized epinephrine can also be used to relieve the symptoms of respiratory obstruction. Epiglottitis is a swelling of the tissues above the vocal cords. That is a supraglottic swelling. This results in narrowing of the airway inlet with the possibility of total obstruction. For this reason, epiglottitis is a life-threatening medical emergency. The onset of epiglottitis is abrupt, and the child presents with classic symptoms. The child insists on sitting up, leans forward with the mouth open, and drools saliva because of the difficulty in swallowing. A cough is absent. Inspection of the throat will show an enlarged, reddened edematous epiglottis, much like a beefy red thumb. The treatment of choice is immediate tracheostomy or endotracheal intubation and oxygen to prevent hypoxia, brain damage, and sudden death caused by respiratory arrest. Acute bronchitis is an infection of the bronchi. Most patients are younger than 4 years of age. The gradual onset of an unproductive hacking cough is preceded by an upper respiratory infection or cold. Most children recover uneventfully with symptomatic care at home. Acute bronchiolitis is a viral infection of the small airways in the lower respiratory tract. The gas exchange in the lungs becomes impaired and hypoxia can occur. An upper respiratory infection or cold with mild fever and serous nasal discharge is followed by the development of a wheezing cough and signs of respiratory distress. The treatment of an infant with bronchiolitis is symptomatic and similar to that of the child with croup. Respiratory syncytial virus is responsible for 50% of the cases of bronchiolitis in infants and young children, and is the most common cause of viral pneumonia. RSV is the single most important respiratory pathogen in infancy. RSV is spread by direct contact with the respiratory secretions, usually contaminated hands to the mucous membranes. An examination of nasopharyngeal washings for RSV antigens can be performed while the child waits in the admitting unit so that diagnosis is established before the infant is admitted to the pediatric unit. Contact isolation precautions should be used to prevent fomite spread. Reporting tachypnea and tachycardia is essential because these vital sign changes could indicate hypoxemia. It is also important to auscultate breath sounds and report any wheezing, rales, or rhonchi. Suctioning of mucus may be necessary to maintain a patent airway. Infants who have a small airway size and are severely ill and hospitalized with RSV infection could be at risk for wheezing and reactive airway disease later in life. Pneumonia or pneumonitis is an inflammation of the lungs in which the alveoli become filled with exudate and surfactant may be reduced. Toddlers often aspirate small objects like peanuts or popcorn and develop pneumonia as a result. Therefore, such foods are to be discouraged for this age group. The symptoms of pneumonia will vary with the patient's age and the causative organism. The cough will be dry at first, but gradually becomes productive. Fever rises as high as 103 or 104 degrees Fahrenheit and can fluctuate widely during a 24-hour period. The child is listless, has a poor appetite, and tends to lie on the affected side. X-ray films will confirm the diagnosis and determine whether there are complications like atelectasis. Treatment depends on the causative organism. Antipyretics should be given to reduce fever. Oxygen is administered for dyspnea or cyanosis. Rest, fluids, and a cough suppressant before bedtime are the basics of home care. Nursing care for all types of pneumonia is basically the same. You can read more about this on page 602 within Table 25.1. Smoke inhalation injury can cause carbon monoxide poisoning. There are 3 stages of inhalation injury. 1. Pulmonary insufficiency in the first 6 hours. Then pulmonary edema from 6 to 72 hours. And finally, bronchopneumonia after 72 hours, which can cause atelectasis. Treatment of carbon monoxide poisoning is often symptomatic and includes oxygen administration, careful monitoring of intake and output, and frequent assessments of arterial blood gas reports. The symptoms of tonsillitis include difficulty in swallowing and breathing. Nursing care involves providing a cool mist vaporizer to keep the membranes moist. A tonsillectomy is indicated only if persistent airway obstruction, repeated infections, or difficulty in breathing occurs. The child is watched carefully for evidence of bleeding, like an increase in pulse rate and respirations, restlessness, frequent swallowing, or vomiting of bright red blood. Coughing, clearing of the throat, and blowing of the nose are avoided to decrease the risk of precipitating bleeding at the operative site. Allergic rhinitis is an inflammation of the nasal mucosa caused by an allergic response. The characteristic signs of allergic rhinitis include nasal congestion, a clear, watery nasal discharge, sneezing, and itching of the eyes. Laboratory tests of the mucous membranes of the nose will show the presence of eosinophils, and skin sensitization testing may be positive for specific allergens. Symptomatic treatment will revolve around the use of antihistamine medications and decongestants to reduce edema of the nasal mucous membranes without creating sedation, which could interfere with learning. The main goals of the nurse are to help the parent identify the difference between the allergy and a cold and provide referral for medical care and support during the long-term allergy testing and immunotherapy process. Asthma is a syndrome caused by increased responsiveness of the tracheobronchial tree to various stimuli that result in reversible paroxysmal contraction of the airways. About 80% of asthma sufferers will have their first symptoms before 5 years of age. Asthma is a recurrent and reversible obstruction of the airways in which bronchospasm, mucosal edema, and secretion of and plugging by mucus contribute to significant narrowing of the airways and subsequently impaired gas exchange. A history, physical examination, and response to bronchodilator therapy are the first diagnostic tools. Exercise testing and pulmonary function tests will help to diagnose asthma and assess the progress of the syndrome. The symptoms of asthma may begin slowly or abruptly. They may be mild, moderate, or severe. In acute episodes, the patient coughs, wheezes, and has difficulty breathing, particularly during expiration. Signs of air hunger may be evident. Asthma attacks often happen during the night. Medications used for outpatient treatment of asthma are for quick relief, in the case of the return of acute symptoms and for long-term control. You can read more about this on page 607 within Table 25.2. Avoiding pet dander, mold, smoking, and dust is essential. Excess humidity promotes mold growth. The use of HEPA air filtering devices in the bedroom and HEPA filters in the vacuum is advisable. The parents and teachers should not exclude the child from physical activity in school due to the fear of triggering an asthma attack. Swimming is best tolerated. Oral fluids are encouraged because they help to liquefy secretions and are needed to compensate for fluid loss from dyspnea and diaphoresis. Cold liquids can trigger reflex bronchospasm. A diet that maintains normal weight is essential because obesity is related to the development of asthma. The importance of exercise to strengthen vulnerable lungs is emphasized. He or she is taught how to use the peak flow meter. Specific information about how often and when to use inhalers is paramount. Spirometry measures airflow and volume during a forced exhalation at a maximal effort into a spirometer. This should be used at a 6-month interval to assess progress. A diary of peak flow reading should be brought to the healthcare provider at each follow-up visit. You can see an example of this on page 611. A meter-dose inhaler consists of a pump that is a mouthpiece and an actuator into which a machine canister is inserted. The child should be taught to rinse the mouth after steroid inhalation to prevent the development of candidiasis. The nurse should help the child see the connections between triggers, medicines, and signs of respiratory distress. During every clinic visit, the nurse should have the child demonstrate the use of the inhaler or spacer and reinforce the principles involved. Status asthmaticus is continued severe respiratory distress that is not responsive to drugs, including epinephrine and aminophylline. This is a medical emergency. Cystic fibrosis is an inherited recessive trait, with both parents carrying a gene for the disease. The basic defect in CF is an exocrine gland dysfunction that includes increased viscosity of mucus gland secretions and a loss of electrolytes and sweat due to an abnormal chloride movement. It is a multi-system disease affecting the respiratory system, digestive system, skin, and reproductive system. You can see and read more about the manifestations of CF on page 613 within figure 25.9. The air passages of the lungs become clogged with mucus. More and more air becomes trapped in the lungs, and small areas could collapse. Dyspnea, wheezing, and cyanosis can occur. The child will appear irritable and tire easily. Changes occurring in the pancreas result from obstruction by thickened secretions that block the flow of pancreatic digestive enzymes. As a result, foodstuffs, particularly fats and proteins, are not properly digested and used by the body. The sweat, tears, and saliva of the patient with CF become abnormally salty due to an increase in sodium chloride levels. The sweat test is the best diagnostic study. CF is often responsible for rectal prolapse in infants and children. Cor pulmonale, which is heart strain caused by improper lung function, is often a cause of death. Nursing Care Plan 25.1 on page 615 summarizes intervention for the CF patient. Bronchodilators are used to increase the width of the bronchi, allowing free passage of air into the lungs. Postural drainage and chest clapping therapy are also of value. These procedures should be done after nebulization and at least 2 hours after eating. Breathing exercises could be recommended for the older child, including pursed lip breathing. Prevention of respiratory infections is essential. An oral pancreatic preparation, known as pancreolipase, is given to the child with each meal, as well as snacks, to replace the pancreatic enzymes that the child's body cannot produce. The diet should be high in protein and calories. Fat-soluble vitamins and iron may be prescribed. The nurse must pay special attention to the skin of the child with CF. The position should be changed frequently. Frequent changes of position will also prevent the development of pneumonia. Mouth care should be given after postural drainage because foul mucus may be raised, leaving an unpleasant taste in the patient's mouth. The goals of care include minimizing pulmonary complications, ensuring adequate nutrition, promoting growth and development, and assisting the family to adjust to the chronic care required at home. The amount and types of diversion required will vary in CF because the disease affects children of all ages and varies in severity. Bronchopulmonary dysplasia is a fibrosis or thickening of the alveolar walls and the bronchiolar epithelium. Swelling of the tissues causes edema, and the respiratory cilia are paralyzed by the high oxygen concentrations and lose their ability to clear mucus from the airways. The main cause of respiratory distress in newborns is prematurity. Therefore, the prevention of preterm births is the best way to prevent BPD. Symptoms of chronic respiratory distress include wheezing, retractions, cyanosis on exertion, use of accessory respiratory muscles, clubbing of the fingers, failure to thrive, and irritability caused by hypoxia. After BPD has developed, the goal of therapy is to reduce inflammation of the airway and to wean the infant from the mechanical ventilator. Fluid restriction, bronchodilators, and diuretics may be prescribed. Ongoing home care is required. And diuretics may be prescribed. Ongoing home care is required, and respiratory problems persist through adulthood. Sudden infant death syndrome is clinically defined as the sudden unexpected death of an apparently healthy infant between 2 weeks and 1 year of age, for which a routine autopsy fails to identify the cause. The peak incidence is between 2 and 4 months of age. The clinical features of the disease remain constant, including that death occurs during sleep and the infant does not cry or make any other sounds of distress. There are risk factors for SIDS. Intrauterine exposure to environmental tobacco use and the use of alcohol or drugs by the mother increases the risk of SIDS. The use of soft mattresses, pillows, and comforters in the crib and an overheated environment are also risk factors. Bed sharing with the infant and the parent is a current significant risk factor for SIDS. Infants should be placed on a firm mattress with no loose bedding surrounding the infant. The AAP recommends that all healthy infants be placed in the supine position on firm mattresses to prevent SIDS. When infants are in car seats, care should be taken to avoid flexion of the infant's head so that the chin rests on the chest, as this can cause oxygen desaturation and hypoxia. Car seats should not be used as a prolonged sleeping arrangement. In talking with the grieving parents after the death of their infant, the nurse must convey some important facts. That the infant died of a disease entity called sudden infant death syndrome, that currently the disease cannot be predicted or prevented, and that they are not responsible for the child's death.